Good afternoon, good evening, everybody. For those who couldn't join us in the morning, my name is Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome. This is the second part of a two-part public health conversation about mental health and trauma, context, and consequences. This event is one of a series of 5 events we'll be hosting through 2022 that follow each of the 5 strategy maps that are cross-cutting foci for our school. In our first session, which was this morning, our panel of experts discussed the mental and physical health effects of trauma and PTSD. In this session, our guests will now discuss placing trauma in a social determinants of health framework. This session is going to be moderated by Dr. Jaimie Gradus. Dr. Gradus, for those who missed her introduction earlier or who are just joining us now, is an associate professor of epidemiology at Boston University School of Public Health and associate professor of psychiatry at Boston University School of Medicine. Dr. Gradus' research interests are directly in line with what we're discussing today, epidemiology of trauma and trauma-related disorders with a particular focus on suicide outcomes. Dr. Gradus is also the intellectual architect of this event and this morning's event. We're very grateful, Dr. Gradus, for being our faculty lead on our strategic direction of mental health and behavior. Dr. Gradus, over to you.
Thank you so much, Dean Galea, for that really nice introduction. And I'm just so honored to be moderating this panel today on a topic that I've been giving really extensive thought to lately, which is that it's time to reconceptualize the definition of trauma from a social determinant of health perspective. I'm so happy to be joined today in discussing this topic by 4 great panelists. First, we'll hear from Dr. Maryam Jernigan-Noesi. Dr. Jernigan-Noesi is founder of Jernigan & Associates Psychology and Educational Consulting, as well as a visiting professor of psychology at Agnes Scott College in Decatur, Georgia. Dr. Jernigan-Noesi's research focuses on mental and physical health disparities among low-income families and the long-term effects on health outcomes. Then we'll turn to Dr. Renee Johnson. Dr. Johnson is Associate Professor and Vice Chair for Diversity, Equity, and Inclusion in the Department of Mental Health at Johns Hopkins Bloomberg School of Public Health. Much of her research focuses on substance use, particularly among young adults, and how social and economic inequality play a major role in mental and physical health. Third, we'll hear from Dr. Emily Mendenhall. Dr. Mendenhall is a medical anthropologist and professor at the Edmund A. Walsh School of Foreign Service at Georgetown University. She has published widely at the boundaries of anthropology, psychology, medicine, and public health, and is the inaugural co-editor-in-chief of Social Science, Medicine, Mental Health. Her latest book focuses on her hometown in rural Iowa and how the community responded to COVID-19. And then finally, we'll turn to Dr. John Pamplin. Dr. Pamplin is a Smart Cities postdoctoral associate and an assistant professor, faculty fellow in the NYU Center for Urban Science and Progress and the NYU Grossman School of Medicine Center for Opioid Epidemiology and Policy. His research focuses on understanding the racialized impacts of enactment and enforcement of policies designed to curb the opioid epidemic, with a specific lens on the relationships between the criminal legal system and the mental health of populations of color. And with that, I'm so pleased to turn it over to Dr. Jernigan-Noesi.
Good afternoon, everyone. It's my pleasure to be here with you this afternoon and to offer some commentary for this afternoon's panel. So I'll be talking about trauma as a social determinant of health, and even more specifically, an area under the umbrella of trauma that I'm really passionate about, which is racial trauma. Just to start, I won't belabor the point in terms of outlining the social determinants of health, but want to just sort of attend to, from my perspective as a licensed psychologist, the conversations that have included topics related to mental health or considerations related to mental health, as well as race. More specifically, the social and community context for me as a psychologist is where I've tended to see conversation, scholarship, et cetera, really focus on what are the relationships. So if we're thinking about integrating and expanding our definition of trauma, what are the relationships and the interactions that individuals and friends, peers, coworkers, and community members are having? And more specifically, what are the quality of those relationships with regard to thinking about the potential for mental and physical health outcomes? So are they those that, embody a sense of cohesion, engagement, or really detract from that. In addition, the characteristics of the context, especially as we think about the topic of trauma, where individuals live, work, and play. What are the challenges that are apparent in those in the social and community context, as well as the notion of safety and experiences of discrimination certainly have continued to emerge in the literature with regard to thinking about the context and social experiences of individuals. As we begin to think about expanding the definition of trauma and really placing it in a framework of the social determinants of health, sort of brings me to the literature in terms of the experiences, the social conditions, even the context that individuals may live in. And I think as a psychologist, certainly in my field and in the social sciences, there's been much more emphasis in really looking at the interpersonal experiences of trauma. So those that may be reflective of, physical abuse, assault, neglect, exposure to violence, and sexual exploitation. I have been pleased to see just the continuance and increase with regard to attention and the expanding definition of collective traumas, for example, which more often historically have been discussed relative to natural disasters, or community-based experiences of trauma like school violence. Cultural traumas, I think, are something that continue to emerge. And I see, again, the movement in the field with regard to really recognizing how the history or the historical definitions of trauma do not quite really map onto some of the additional experiences that may lead to traumatic stress response and potentially rise to the level in some occasions of post-traumatic stress disorder, which I'll talk about. More specifically, though, as we think about the experiences of individuals, right, in those social contexts, the experience of individuals that may identify as refugees, as well as the increasing conversation that really looks at race-based traumatic stress and ethnoviolence as a source of traumatic experience, and the really intersection of historical traumas, intergenerational traumas, and all the ways in which we are continuing to define those. And I think especially relative to the current context that we're living in, that being the pandemic, there's been increased conversation with regard to experiences of loss and all of the variation of those experiences of loss, but really as being a potential source of traumatic stress for individuals as well. As someone who has been always interested in really thinking about the social and ecological experiences of individuals, I often encourage us to think about race is a particular area of interest for me, race and ethnicity, as well as other aspects of culture and intersectionality. But I will focus on, as I said, race and race-based trauma today for the brief time that I have with you. I often encourage folks, as opposed to really looking at the popular literature and the historical ways in which race has been examined relative to thinking about the social determinants of health, to mental health, to even health outcomes, rather than sort of looking at race from a comparative standpoint, really highlighting disparities. How are we using, this is my magnifying glass, right? Really a lens to understand race as it pertains to health outcomes. And just a quick survey of the literature relative to public health as well as psychology, as we look at health outcomes, and that includes mental health. There certainly has been documentation of the limited access to social resources. So the disparities that may exist for people, individuals, and communities of color relative to their counterparts. In addition, there's a scholarship that highlights the increased exposure to risk factors, again, sort of looking at racial categorization as a factor relative to studies and findings. And also within the health research, more attention to experiences of racial discrimination and its impact on individuals from both a neurobiological as well as physiological standpoint. Literature also tends to focus when talking about race, right, and the integration of race, really looking at the experiences of individuals that may identify as people of color relative to those who self-identify as white, and really focus on the idea, again, in those comparison studies of sort of reduced engagement, what that may mean with regard to health promoting behaviors or using health compromising behaviors as coping, particularly when we're looking at health outcomes. And again, an emerging body of literature that really has begun to outline direct injury, and I think often relative to physical injury due to racial violence. So for me, more of the conversation, I won't say a lot, but more of the conversation has really looked at this notion of race and, right? So really relative to and an ancillary way to the other social determinants of health. And my research, really, both from a clinical perspective as well as a clinical research perspective, is really about understanding the experiences of racism and racial discrimination, racial violence, racial harassment from a contextual standpoint. It's recognizing that our current definitions of trauma do not always account for the prevalence of experiences that may lead to traumatic stress response, including racism and racial discrimination, across the lifespan. So the potential accumulation and ongoing nature by which racial stressors may lead to racial trauma. In addition, as we think about our definition of racism, we tend to focus on interpersonal ways in which racism and racial discrimination may present. And as conversations more widely begin to expand, right, there's increased recognition of understanding the historical, intergenerational, cultural, influences of trauma, in addition to, I would say, from a societal level, are more recent, I'll put in air quotes, conversations relative to systemic racism. So as we think about, again, that definition of racism, and we think about context, for me, it's an encouragement of both recognizing interpersonal racial trauma and the potential, but also the exposure to, right, discrimination in an institutional, structural, systemic way. And, right, the associations that have been documented with regard to those experiences and poor health and mental health outcomes. So race-based traumatic stress understands the perception of an event, if there is an event, but also recognizes that exposures and other types of experiences or triggers lead to negative and painful responses, which can rise to a certain threshold, right, and vary by individual person. But those experiences, as described according to our clinical research, are often unpredictable, uncontrollable, sudden, unexpected, really align with some of the previous trauma-informed literature, but also begin to, as I mentioned, expand beyond our current definitions. Here on the slide, I won't go through everything that's present, but according to, I'd say, clinical research in the past 10 to 15 years or so, we do have sort of a profile that really outlines the overlap between race-based traumatic stress and some of the symptomatology that presents for individuals with regard to multiple domains. So physiological, as well as thinking about the psychological, behavioral, and relational implications. And more specifically, sort of looking at the impact to the body relative to sort of medical the potential for comorbidities with regard to medical conditions, but also, right, in terms of consequences, looking at the impact of the sense of self, to identity, to self-efficacy, looking at and really understanding in context what this means in terms of students in schools or individuals in terms of places of employment, and how that relates to, right, the information that we've documented with regard to substance use or health compromising behaviors, as well as, right, the relational impact. So seeing, for example, in relationships for individuals, withdrawal, isolation, and in some cases, risk for exploitation. So as we think about sort of addressing racial trauma, and I hope to certainly offer additional comments during the discussion portion of the panel this afternoon, for me, it's really about reminding ourselves to both recognize the tendency to focus on interpersonal examples of racism and racial discrimination that may lead to racial trauma, but also to begin to integrate that examination of the multiple ways in which, right, we define racism and their impact. It is using the developmental and contextual and lifespan frameworks to really emphasize the unique nature of cumulative risk and the intersections with regard to other aspects of individual identity. It requires us to really begin thinking from a collective standpoint, because racism may, in some cases, there may be an individual incident, but racism happens to individuals and to communities. And so how do we move away from the interpersonal and individual healing models to the collective and community-based models from a proactive and protective standpoint? And I can certainly speak more to this later on. I'll stop here by just sort of reminding us to really think about the multi-level understanding and approach that's necessary when thinking about trauma in general, and for me, more specifically, racial trauma and ethnoviolence. Ideally, we overall are reducing racial disparities that have been so well documented in health and mental health care, the morbidity related to chronic health conditions, and really proactively buffering, right, the impact of trauma on individuals and on the population in an effort to improve overall emotional well-being. So I will stop there.
Thank you so much, Dr. Jernigan-Noesi. Yeah, that multi-level consideration is so important, and I hope that we get to discuss that a lot more during the question and answer portion of today. And now I'll turn it over to Dr. Johnson.
Hi, everyone. Thank you so much for having me. So today I'll talk about using data from the Maryland Youth Risk Behavior Survey, or YRBS, to characterize adverse experiences among youth, and also talk about the role of structural determinants in experiencing adverse experiences. So increasingly, folks who study youth are recognizing that adolescent risk behaviors are really a response to trauma and adversity. Nearly 1/2 of Americans have been exposed to at least one adverse childhood experience before turning 18, and these ACEs contribute to a broad array of problems, including physical health problems, mental and behavioral health problems, and psychosocial functioning challenges. However, what we know most about adolescents is the risk behaviors. And we know that from adolescent health surveillance programs. So what we're doing in public health is a really good job at counting some of the outcomes, i.e. risk behaviors, but not the contributors, meaning adversity, until now. So I'm really happy to be talking about the 2018 Maryland YRBS, which is the main surveillance system for the state of Maryland. It's administered every 2 years in public schools in the state and powered to represent all of the counties. And for the first time in 2018, the system looked at 5 adverse childhood experiences, or ACEs. And here are the childhood experiences that were included. And I'm happy to say that this was the result of advocacy of a number of people, including social workers in the state, saying that this surveillance system would be more useful to them if they had information about adversity as well as risk behaviors. So I will talk about the prevalence of ACEs, associations with emotional and behavioral problems, variation by race and Hispanic, Latino ethnicity, contextual, and then finally contextual factors as predictors. So not surprisingly, and this is consistent with the literature in general, the prevalence of ACEs is quite high. About 30% report that a family member has mental illness. Nearly 25% reports parental gambling or substance use. 24% report family member being in prison or jail. About a fifth report caregiver verbal abuse, and about 17% report food insecurity. And then when we break it down a little differently, more than 1/2 of the students in Maryland report at least one ACE, at least one of the 5 ACEs we asked about. Again, not surprisingly, ACEs are strongly associated with emotional and behavioral problems. So young people who, I just chose 2 to discuss on this slide, but let's just think about young people who report a family member who's been to prison or jail. They're more than 2 times more likely to have poor school performance, more than 2.6 times more likely to be engaged in fighting at school, more than 2 times likely to report suicidal ideation or recent emotional distress, and more than 2.7 times likely to report past 30-day marijuana use. And this shows across a variety of behaviors. Okay, so this slide is a lot, but I'm going to break it down. So across the top are ACEs, and then that's like each big column is an ACE, and then these little columns here are race differences. So the first thing I want to say is ACEs, the prevalence of types of ACEs vary by race. So you'll see here that among Black students in Maryland, about 1/3 reported that a family member had been to prison or jail, and this was the most commonly reported ACE. However, when you look at white students, and they're represented by the red dot, the most common ACE was mental illness in the family. Asian students are the purple dot, and for each specific ACE, as well as multiple ACEs, they reported the lowest prevalence of ACEs. So this is that same table I just picked out, just the prisoner jail piece. And among the multiracial folks, we looked at what races were you Black and Asian, Black and white, and more than 60% indicated they were Black and another ethnicity. So Black, Latinx, and multiracial students reported very high levels of having a family member who'd been to prison or jail. And we're thinking about trauma and adversity. How are our youth serving systems set up to respond to the trauma that goes along with a family member being in prison or jail? And I'll note that in the city of Baltimore, this number is above 50%. As I just said, Maryland high school students with a family member who have been to prison or jail are more likely to report emotional and behavioral problems. This is consistent with the existing literature, including Mia Hurd-Garris's work from Northwestern. And it really makes you think about what this graphic is showing, is that we're looking at young people's emotional and behavioral problems, but those are really reflections of adverse experiences. And then we can look at adverse experiences and think, wow, those are really shaped by social and structural determinants. So the take home here is that criminal justice system policies and practice are a structural determinant of emotional and behavioral problems among adolescents, especially Black, Latinx, and rural youth. We wanted to test this hypothesis empirically to see, could we look at some contextual determinants and see whether they were actually related to the prevalence of ACEs. And another wonderful thing about Maryland YRBS is that it's powered so that we can look at each county individually. So I, with a team of folks, looked at area deprivation index and rurality. A lot of people think about mass incarceration as it applies to Black folks, but it's much less focused to look at over-incarceration among rural folks. And I'm here to tell you it's actually a really big problem. Jails in rural areas are more common than substance use treatment. Like de facto, that's where people go when they have substance use problems. So anyway, we did a multivariate longitudinal regression to estimate odds of ACEs in association with this measure called area deprivation index, adjusting for some covariates. And what we found, and I'll just focus because of time on the family member in jail or prison piece here, is that for those who had a family member in jail or prison, they were more likely to live in a county with a lower ADI score, meaning in a county with more impoverishment. And they were also more likely to live in a rural county. Young folks were also, who experienced ACEs, who experienced substance use, parental substance use or gambling, also more likely to live in low ADI counties and rural counties. And those experiencing food insecurity, this makes intuitive sense, were more likely to report low ADI scores. We're more likely to live in counties with low ADI. So the main lessons here are that ACEs are common, differentially distributed by race and Hispanic Latino ethnicity, and greatly increased risk for adolescent risk behaviors. And I'll add that we really should be looking at ACEs we should be thinking about surveillance data in terms of ACEs. It was really beneficial for Maryland to have included ACEs on the YRBS. Second, contextual factors such as area level deprivation and rurality are associated with increased risks for different types of adversity, including family member imprisonment or food insecurity. And then finally, and here's the take home and what's most relevant to this panel today, is that addressing structural factors such as food access, family financial support, imprisonment as a sanction for criminal behavior, or even just offering young people who have a family member who has been incarcerated extra supports that they might need. These are strategies for primary prevention of ACEs.
Thank you, Dr. Johnson. Really excellent work. I'm excited to talk about it more during the question and answer period. And now I'll turn it over to Dr. Emily Mendenhall.
Thank you. Well, hello, everyone. It's really a privilege to share this space with you. I'm going to talk about really similar things, but a little bit differently. When I tell the story, I'm going to be focusing mostly on some work I did a little over a decade ago at Cook County Hospital in Chicago. So I'm going to start with a story. Lupe grew up in a small village in Mexico. Her husband grew up in a neighboring village, and they were sweethearts at a young age. They married before they migrated to the United States, but crossing the border was not an easy task. They failed 3 times under arduous conditions before they arrived in the United States. They brought their first child with them from Mexico and had 3 more together after they settled into their new life. But life was not like it was in Mexico. Work was hard to find, and Lupe's husband became abusive towards her. This angered her deeply, but she never left him. She feared what life might be on her own. In many ways, she found insecurity in her new life. This insecurity was compounded by her middle child disappearing at age 12, and she never resurfaced. Today, she worries mostly about her living children, especially the eldest, who has diabetes and doesn't try to control it. Lupe describes worrying a great deal about her own diabetes and closely watching her diet, but she spends most of her time alone and often forgets to take her pills. Lupe rarely exercises because she doesn't feel safe walking in her neighborhood alone because gun violence is common. So one of the goals of this talk is to talk about the conceptualization of trauma as a really messy, non-static entity. I argue in my book, Rethinking Diabetes, that trauma of force location and fragmented social worlds cannot be removed from this story because real biological and pathological pathways of trauma and chronic stress lead to diabetes, from epigenetics to psychophysiology. And I really put the messiness at the center of the story in how we think about diabetes as embodied trauma. And in this way, we can think about the influence of diabetes the influence of trauma from, from gestation to early life, to childhood, to adolescence, to early marriage, to the experience and complexity of caregiving throughout your life, has all mutually embedded and overlapping in part of this really important story and experience that humans experience that, obviously differ from intersectional ways, especially the women I spent time with in Chicago, experienced a lot of stress due to undocumentation and the immigration process in the United States. So just really quickly, what I'm talking about today comes from 121 in-depth interviews. The shortest interviews were about 4 hours, the longest were about 6, with women at Cook County Hospital in Chicago. 1 in 3 were undocumented. Many had undocumented loved ones. I did extensive life history narrative interviewing and a bunch of checklists and medical details. And I'm going to talk a little bit about this specific piece, which was a look at what symptoms of trauma and PTSD itself as a diagnosis really meant. And I'll talk about the constructions of trauma in this data in an important way, because how we look at trauma and how it's measured sometimes obfuscates the actual embodiedness and embeddedness of trauma in people's lives. And I often use and have used the perspective of diabetes as a way to think about trauma and to think about how trauma is embedded in a life story, but also how so rarely is it one acute experience and recovery, that the experience is complex and rooted in a life story and a family and a community, and also a policy environment that often causes a lot of harm. So the women I interviewed, 1/2 had moderate or had some depressive symptoms. 1 in 3 had severe to moderate depression. 2 in 5 reported symptoms of PTSD using a standard checklist. And I also looked at idioms of distress, of specifically coraje or anger, susto, a fright, or also nervios, kind of an underlying anxiety, to learn about how people were conceptualizing on their own terms and talking about non-biomedical ways of how they experience, embody, and cumulatively understand their own trauma in their own lives. And when I did a standard checklist, there were a number of traumas, especially on the ACE scale, but really my interviews were asking, tell me your life story. And from those life stories, looking at what traumas women found really salient in their lives. And it was about a mean of 3 that they would bring up in their lives. The highest number was 12, but mostly they're about 3 to 4. One example of a woman who was pretty hypervigilant said, everything scares me. Getting on a bus scares me. Riding in the backseat of cars scares me. People who I don't know who come around with my family. If I don't know them and I think they're giving me a look, sometimes, something, scares me, mostly male. People that don't know me, they ask, why are you so jumpy? So then sometimes I have to sit on my hands, cross my legs so I don't shake or shriek. And thinking about what in her story has contributed to these symptoms that we might categorize and treat for PTSD, but how they're not just this one experience, but in fact, they're cumulative and complex and overlapping. So in this piece, we take away these 4 things that I think are really relevant to this conversation here. So PTSD symptoms, although useful and important, especially in the field, in this domain of getting care and legitimating care through insurance, they overlook cultural expressions of suffering that often occur as a result of trauma, like how people often around the world talk about trauma in the body or of the body or in their social world. And often PTSD symptoms are very individualized, which kind of complicate how a lot of people think of disease or illness as inherently socio-spiritual or emotional. And often, this concept of PTSD as it's treated overlooks the cumulative effects of trauma, and just emphasizing how important a cumulative trauma approach to cumulative trauma is, especially for the women I've interviewed here. And I've also worked other places around the world and have found some similar things, although really different cultural nuance, which would be expected. Then also PTSD and depression, as clinicians well recognized, are closely linked to each other, influence symptoms, and are overlapping. And it's important to recognize that. And there's a lot of really good work looking at how cultural idioms that I mentioned can be really important markers of overlapping other psychiatric disorders. And then finally, PTSD diagnosis is currently and/or while it's best looked at as a continuum and as a complex issue that isn't just thinking about one trauma in childhood that is affecting you throughout your life. Although I do write about this woman, Rosa, in Syndemic Suffering, that talks about how she conceptualized this trauma from her childhood, which was an extraordinary trauma of being kidnapped and dislocated from her family for many months, with her with almost a PTSD, a sort of re-traumatization through her chronic illness, because she had actually a very long, successful life between these 2 traumas, and how they become embedded and enmeshed in her story, and how she conceptualizes herself and her mental health as she really grapples with this trauma. So, thinking about the complexity through which people are perceiving their own trauma is really important. And one of the things I argue is when we think about chronic illness, specifically if we're thinking about diabetes in America, especially how it afflicts, Black and Brown communities much more than, not only, but much more than white communities, and how chronic untreated depression becomes this partner, especially when people throughout the world have limited access to mental health care. And that may be from a psychotherapist, a community health worker, a neighbor, maybe a religious leader who can provide that comfort, especially if you've experienced trauma. And the epidemiological data shows how this persistent, untreated anxiety and depression can become embodied in diabetes. And there are biological and social pathways that link diabetes and depression together. And I think about this. This is a really good piece. There's really good and really important work on diabetes and depression. And it comes back often to these kind of conceptualizations of causes of traumatic experiences that then are held within. I think about them sometimes as being held within the soul and carried with people as they travel through life. So if you're not provided, care or an outlet as you experience one trauma or another, and so many women I talk to around the world have said, well, I haven't shared my rape or some sort of violence throughout my life. And I think that's really become embodied in my diabetes. And a lot of my work with women, older women with diabetes, I find that women have experienced some sort of violence. And I think that having a metabolic condition, and there is data looking at this, but it's more likely if you not only have experienced this kind of violence, but also if you've carried it in silence. So these kinds of moments of silence around trauma are really persistent. And one of the outcomes actually of our work in Chicago was doing a comprehensive domestic violence screening and trauma screening among primary care seekers. So how I've conceptualized this somewhat is changing our focus on what an outcome looks like. Often diabetes is a great gateway into federally qualified health centers or this public hospital at Cook County, and really shifting the idea of the outcome as being diabetes, but thinking about the outcome as a conceptualization of a syndemic. So moving from individuals to populations, but thinking about how diabetes becomes entangled with depression. But it's not just diabetes and depression that travel together and cluster among individuals, but there's also these hidden traumas that people carry with them and have to really be considered and really valued as part of people's story and part of how people need to heal. So I might leave it there. Thank you.
Thank you so much for sharing that great work, and those stories are so moving. I'm looking forward to speaking about them more in a bit. And with that, I'll turn it over to Dr. Pamplin.
All right. So first of all, thank you so much for inviting me to be here. I'm really looking forward to chatting with you all a little bit, thinking about policing, especially within this context of thinking about social determinants and trauma. So for many people in this country, there's this assumption that if you're not doing anything wrong and if you're not breaking the law, there's really no reason to be worried about the police. You'll probably never interact with them. And though that's true for some people, it's not really the case for folks in predominantly Black and Latinx communities. Policing has been heavily racialized practice in this country really since its inception, and it's no different today. These inequities are highlighted, especially in conversations around mass incarceration, where 1 in 3 Black men in this country will go to prison at some point in their lifetime, compared to 1 in 17 white men. These numbers, they're not a reflection of individual racist actors, but they're the manifestation of a series of policy decisions, all of which disproportionately target Black and brown folks. And so this includes things like broken windows policing, stop and frisk, and the US war on drugs. And so if we can highlight an example from the war on drugs, Black people are overwhelmingly overrepresented in the prison system for crimes involving cannabis. At one point, a report from the American Civil Liberties Union showed that Black men were 4 times more likely to be arrested for possession of cannabis than white men, despite the fact that, as illustrated here, and this is data from the National Survey on Drug Use and Health, Black people their use of cannabis is really equal or even lesser to that of their white counterparts, excuse me. And the truth is, these racial inequities in the criminal legal system and their outcomes have persisted for literal centuries. And it's because they continue to be reproduced even in the face of changing policy. So the figures here are from a paper I'm working on, and it's led by a colleague of mine, Dr. Spruha Joshi. And we're looking at changes in cannabis-related arrests in Washington, D.C., following decriminalization and subsequent legalization of possession of small amounts of cannabis. And so in each frame, the solid Black line is the rate of arrest for Black people. The dotted line is the rate of arrest for white people. And then the red and blue bars represent decriminalization of small possession and legalization, respectively. And what we see is a really large disparity in possession arrests in the top left box, but it disappears once possession is no longer an arrestable offense. However, arrests for the remaining non-possession offenses increase following those policy changes, and they do so disproportionately for Black people. So that disparity that I highlight is just one example of racial inequities that are experienced at every stop within the criminal legal system. Black and other people of color routinely experience increased risk of being stopped by the police and of being searched if they're stopped, of being arrested once stopped, being convicted once arrested, and of being harshly sentenced once convicted. The overall point here is that I think we need to understand when it comes to conversations of policing and this idea of, what are the social determinants that might inform trauma exposure, is that in this country, policing is not experienced uniformly. It differs considerably in predictable ways based on axes of a person's identity, their socioeconomic status, their mental health status, and characteristics of their neighborhood. And it differs in two really important ways. So the first way is just about presence. So for every conversation about increasing police presence or activity in a city, the silent part of that conversation is we're not talking about increasing it uniformly across all parts of the city, just certain ones. And then the second point is that not only is police presence variable across the city, but the way in which police operate differs too. So many of the outcomes that we focus on in conversations of police interactions, so things like arrests and incarcerations, those are really just a small proportion of the outcomes that are experienced in kind of over-policed communities. Many of these other outcomes either don't really exist on the radar for people outside of these over-policed communities, or because they're outside of their frame of reference, it's hard for them to understand how significant they are. But nonetheless, these more common interactions have the potential to produce trauma for those who experience them. And so that's what I want to touch on briefly. So often absent from these conversations about policing are the people who are detained, but ultimately released without charge. And for some people, it's easy to hear that and think, all right, well, they were released, so no harm, no foul. But that kind of sentiment illustrates a lack of familiarity with what it really means to be released what it means to be detained. So in the US, law enforcement is able to lawfully detain an individual for up to 72 hours before presenting formal charges to a court. This means that they can put you in a holding cell with no evidence of any wrongdoing. And as long as they release you by the time that clock expires, it's considered a lawful act. The exact amount of time that you can be detained varies by state, but it's really not a hard rule. So you can be detained beyond 72 hours if that kind of clock expires during a time in which the court is closed. So this is like over the weekend or during a holiday. But either way, it's really important to understand that even being detained for as little as 24 hours, which is the maximum in New York State, it can have really, really large impacts on your life. So it can mean loss of employment or termination of your custodial rights. It can result in disruptions to medical treatment or access to medications, especially for people with chronic physical or mental illnesses or substance use disorders. And it comes with the increased stigma and potential for increased exposure to harassment and violence, which are all associated with police detainment. We don't have a great sense of exactly how often this occurs because it's not a statistic that law enforcement agencies report, but it's commonly reported among people who are from over-policed communities that it's something they experience regularly. And in fact, it's reported as a tactic that they believe officers use to try to harass individuals. But because it's not considered an unlawful act, as long as the person is released within the state's window, there's no real recourse for an individual who's detained, despite the consequences that they have to face as a result of that detainment. And the lack of documentation of these scenarios means that there's not really a mechanism for police accountability if there's an officer who does this kind of routinely or serially. But even if you're not detained by police, there are still the folks who experience stops at the hands of police. So this is a figure from a report from the New York Civil Liberties Union, and it focuses specifically on stops of people who are found to be doing nothing wrong. It's between 2014 and 2017, and the key thing here is that the vast majority of these stops are for people who are found to be doing absolutely nothing wrong, upwards of 80%. But if we focus just on these stops where people are doing nothing wrong, we see that 2/3 of the Black and Latinx individuals who are stopped are still frisked by the police officer compared to only half of the white individuals. And I don't think we can understate how demoralizing and humiliating it is to be publicly frisked by an officer. especially given how powerless it feels knowing that, even anything perceived as resisting can have severe consequences. And to highlight that reality, approximately a quarter of the innocent Black and Latinx people who were stopped still experienced use of force at the hands of the police, despite being innocent. So there is a racial disparity in these numbers, and that's important because it highlights how these fears are much more real for people of color. But at some point, it's worth a broader conversation about what it means to have a society where police end up using force against 1 out of every 4 to 5 innocent people that they stop. And either way, it sets up the realities of just how not benign these stops are. So each time there's that fear that they could end in humiliation or they could end violently, despite not breaking the law. And again, you're powerless to do anything about it. So that's a tough realization, even if being stopped is a relatively unlikely experience. But for people in over-policed communities, this experience is part of their day-to-day life. And so this is a screenshot from a video published by the Guardian newspaper. I encourage folks to check it out if you get a chance. They're interviewing a young man from Brooklyn who discusses being stopped and frisked by police over 100 times during his adolescence. And his story highlights that police practices are not distributed across the entire city or of whatever city, but they're concentrated such that small numbers of people experience daily what others would imagine is more of like a once in a lifetime occurrence. And I do want to point out that his experiences reflect kind of the height of stop and frisk use in New York City. In 2019, there were still over 13,000 stops by NYPD, and 88% of them were on Black or Latinx people. The last thing I want to point out is that the impacts of being in an over-policed neighborhood extend beyond whether you're the subject of a particular interaction, because it fuels this constant state of vigilance out of fear of being potentially the next hashtag. So, cell phone cameras and the internet have shown us all how being a victim of police violence can happen, whether you're shopping in a mall, at a routine traffic stop, or even your own home. And not only are these stories more readily accessible, but for the first time in history, a generation of people were routinely exposed to actual video footage of people who look like them being killed by the police. And so this photo is an example of a disclaimer that has been added to a lot of these videos in response to people expressing outrage at the cavalier nature in which videos of Black people dying at the hands of police were circulating in social media freely. And so I just want to say that really, to understand the potential trauma of living in an over-policed community, it requires understanding what it means to watch multiple videos of people who look like you, your family and your neighbors being killed while doing routine non-criminal activities, while constantly hearing story after story of your friends and your neighbors and their most recent close call interactions with police, while then being expected to go about your own daily activities while there are officers present in your building lobby or on the train or outside the grocery store, all while trying not to act nervous because knowing that if you do, that can be considered grounds for them to come and stop you too. So increased police presence often means different things for different communities. And at the heart of that difference is what it means to be a community that is protected and served by law enforcement versus one that is policed by law enforcement. And for that latter one, arrests represent really just a small proportion of those encounters between officers and community members, but they're far from the sole drivers of potential traumatic experiences at the hands of law enforcement. And so that's the focus of a current project that we're just starting now, where we're trying to gain a fuller picture of the disproportionate experience of policing across different neighborhoods in order to better understand the impact of it on mental health within those communities. At the end of the day, police provide a response to crime, not necessarily prevention. And we know that investments in community in terms of education and economic opportunities go a lot further towards reducing crime in a neighborhood than increasing the police presence. So it's worth asking ourselves now, as there are debates all over the media about whether to increase or decrease presence of police in our cities. How often is the person asking for increased policing a member of a community or neighborhood in which they are likely to be a target of increased policing? Do they live in a neighborhood where those extra officers are likely to actually be stationed? Are they considering what the increased police presence may mean for the psychological well-being of folks who do live in those neighborhoods? Because if not, maybe their voice shouldn't be so prominent in deciding whether over-policing a community is a net positive. And so with that, I'll thank my collaborators and thank you for inviting me.
Thank you so much. Wow, that was really excellent. I appreciate all of these talks so much, and I'm so excited to move on to the discussion portion of our panel now. Please put questions in the Q&A section of the chat for our panelists, and I'll happily moderate those as we go. I'm going to kick us off with a couple of questions of my own. The first is that actually during those presentations, I wrote down a list of words that were striking to me, and I'm going to read them to you right now. Structural, historical, multi-level, context, community, policy environment, cumulative, external environment, sociocultural factors, centuries, and police practices. And I was really struck by just how much throughout all these presentations, and if you think about trauma broadly, it really is the outcome of these systemic policies and systemic ways that society is run. For many people, traumatic events are the outcome of those things. But there is this tension with the way we treat trauma as sort of an individual experience, that the onus is then on that person to overcome. And so what it was making me think was, there's a challenge there, right? With people not really even realizing necessarily the ways that things impact their life and how those things are the result of, hundreds of years of repression or structural racism and things like that. So I guess my question for the panel, for any thoughts anybody has, is, how do we overcome this tension between trauma really being the result of these systemic issues, a downstream consequence of systemic issues, but that also on an individual level, it might be hard for people either in a clinical setting or a research setting to even appreciate that in their own lives, to be able to report about it.
I think I am understanding your question, but it was long. But here's one thing I would say in response. I think the people who are targeted by police and other forms of structural disadvantage know that it is oppression, know the purpose it, holds in society in terms of power and keeping people down. I think it's actually scientists who are slower to the table in identifying this. And I think we spend a lot of time looking at, bio under the skin factors and genetics and DNA. But then when it's time to really look at centuries old practices and how the policies and the social stuff shapes risk for adversity, it shapes your life, then we fall down and our science is nowhere near as strong as it is for some of the biomedical pathways. But I think, the people that Dr. Mendenhall were talking about, they know they're being targeted by the government and they know it's about hatred, I think, but I could be wrong on that. And maybe I misunderstood your question.
No, that's exactly right. And I was thinking more that there's sort of a range of experiences, right? So there's obviously, police brutality and just policing in general is a more sort of obvious one, where you realize that you're being targeted, but perhaps there are other experiences that, are so historical and just the consequence. I don't know why, like redlining is something that's coming to mind, right? That people may not exactly realize that some of the consequences of how they live now are an end result of that. John, you were going to say something.
Yeah, well, because I think there's a mix. I think you have the people who know very well about these systems and are willful, and I think you have a lot of other folks who don't know, but it's their privilege that has allowed them to not know. To your point about redlining, I think if you are someone who is living in a much better off, wealthier, whiter neighborhood, and you look down at the poor Black or brown neighborhood on the other side of town, to not acknowledge or be aware that there is a structural history behind that, to me, is a willful ignorance at this point, because that information is quite out there and available. I think for myself, I do see, even for examples like the presentation I gave, I kind of have an attitude of like, you don't get to be willfully ignorant around me. Like, here you go. Now you are informed. And I think to the other point that, right, I do think the scientific community as a large has given a lot of cover to people for a long time to not know, or to kind of continue to focus on individual at the expense of the structural.
Yes, that makes a lot of sense to me. Other thoughts?
Yeah, I'd like to add to that. I think this, for me, and this from as a mental health provider, sort of thinking about the decades of research and interviewing folks around their race-based experiences in particular. And I think this is where the social, political, historical, sort of that importance comes to mind for me, especially this at the societal level, what the rhetoric is. I'm thinking of across the lifespan. And across, sort of different periods in history, I absolutely, as I think about, for example, my parents' generation or my grandparents' generation and kind of their experiences with regard to race and sort of the explicit messaging or exposure, right, would influence sort of how they see and understand and experience. I would absolutely agree with Dr. Johnson, right, that folks, again, thinking about race of color, sort of know. And at the same time, what's been noteworthy for me more recently is as I work with younger generations of, say, adolescents and emerging adults, where the societal rhetoric, right, which has been sort of denial, minimization, dismissal of race-related experiences, that has influenced to the degree, right, if we sort of think about community and context and caretaking environment, if you have caretakers and folks in the community who are speaking explicitly about race and sort of providing those racial socialization messages, then youth are able to sort of see and acknowledge and feel validated, even if, say, a school environment, right, is not validating their experiences. For other youth that I've worked with, though, when they're getting these messages from school environments that sort of racism, right, isn't a thing. And I'm going back a couple of decades, but it's not as bad, right? So sort of some of those societal messages, it creates and facilitates a level of confusion that is noteworthy for me, because they are experiencing on a day-to-day basis things that they, may feel embodied, right, or in their bodies, and certainly may impact their mental health, their behavioral health outcomes, even their academic outcomes. But their immediate environment, meaning adults that may be present in some parts of their community as well as the schools, have historically sort of minimized some of that. And if there's not the counter narrative, right, of validation, what I find noteworthy from a mental health perspective is that's where I tend to see this emergence of impact to self-esteem, to identity, to thinking about how it is that they're coping with, right? So some of the interesting research that begins to look at the experiences of racial discrimination for adolescents and emerging adults in particular, and its relationship to substance use, right, as a form of coping, has everything to do with sort of the contextual environment in terms of how they're being validated or not. So I'm simply saying, as you said, for me, it's not an either or, it's kind of sort of a both and it's developmental, it's cumulative, and it's social, it's historical. So I think it is complex. I think very much so noteworthy. The youth that I'm working with today, right, are experiencing a very different divide, so to speak, with regard to race, right, and race-related rhetoric at a societal level that's different than youth I worked with, 20 years ago. So their experiences are going to be different. And as was noted in Dr. Pamplin's presentation, they're exposed to, right, very, very literally images which are impacting their experience of race-related stress. So just to add to what was already offered.
Yeah, thank you. And Dr. Mendenhall, would you add anything?
Yeah, I think my colleagues here have brought up really important points and eloquently described some of these complex issues. And I think one of the things I'll speak to is something Professor Johnson talked about, because I think it's really important to think about the fact that what harm does medicine in public health do by suggesting these individualized opportunities or interventions that are going to fix trauma. I think we see it again and again as there's all of this stuff that puts everything on the individual, and by and that's our culture, right? Our culture is hyper individualized, and we think just do this meditation, you're going to be fine. Or like if you have access to a psychotherapist, just do the work and you'll be fine. But the complexity and the kind of everyday mundane kind of microaggressions and harassments that are traumatic, as long as the kind of direct kind of violence that we've all been talking about. These are things that become compounded, and without addressing policy issues, nothing's going to get fixed. At the end of Rethinking Diabetes, and diabetes is a good case to talk about trauma and embodied trauma and intergenerational trauma, in part because what the solutions are are addressing housing policy, food policy. Also, let's talk about racial capitalism and, tackling corporations that, are, pry on, low-income communities, communities of color with really crappy food. So all of these things become kind of, and it's easy to ignore that in our society, to ignore the kind of harm that's done through these structural dimensions and policy decisions, because in America, we put profit before people all the time. And, that's really at the heart of our sickness. Obviously, it's not the only problem, but, it's in, putting corporations first is, erasing histories of violence and the complexities that are, behind this kind of power of racial capitalism that really make our society sick.
Thank you. Thanks. That was a lot to think about. So even though all of this is very compelling and we've had very compelling presentations and the discussion so far has been compelling, the trauma definition, the official definition put forth is what it is. And so what would you say are the biggest action items that people could get involved with at this point to actually work towards change with regard to reconceptualization of trauma as a field? And that's to anyone on the panel.
I guess I would say in the one thing we could think about in the same way that we think about partner violence in terms of there's a movement to look at the people who are doing the violence and not just the people who are experiencing the violence. I think in thinking about trauma, we should move from not just people who are experiencing the trauma, but people who are perpetrating the trauma, and think about policies and how they will adversely impact people. So if you say that people without papers are not allowed to work in this country, that leaves them vulnerable to be terrorized at whatever low-paying job they get, because their supervisors can do anything they want to them because they know that they've got this power and they can get someone deported, or they can, whatever. So that policy is trauma inducing. So I think like the way we conceptualize trauma takes away any actor. And I think it would go a long way toward putting the actor back in. These things didn't just happen to people, they were done to people.
Yeah, and I think that's feels really consistent with what might have been my poorly worded first question. Other thoughts? John, were you gonna unmute and say something?
So I think I've run into this kind of issue in a number of different spaces. I also have a big chunk of my kind of scholarship is thinking about kind of racial paradoxes in terms of depression. And the thing that I run into time and time again when I talk to, non-academics, especially, people of color, and I explain this idea, they're like, well, maybe we just are experiencing depression differently than how, DSM decides we're supposed to. And it's one of the most frustrating things about, doing psychiatric epidemiology for me, because the outcome is defined based on how DSM sets it's a circular argument, right? Because then the response is, well, if you're experiencing something that's not this DSM defined thing, well, you're just experiencing something else. It's not depression, or in this case, well, then it's not trauma. And I just want us all to take a step back and realize how ludicrous that is in so many different respects, right? And I think that's the first step of this, is recognizing that if in all of, we're at a moment in time where we're very interested in heterogeneity of different things, and to think that there's not a heterogeneity inherent to what it means for trauma, especially in people who have completely different life circumstances, it's, I think, a bit naive. And I think that's kind of the first piece to kind of push towards reconceptualizing what trauma means.
Great, thank you. Dr. Jernigan-Noesi or Dr. Mendenhall, Dr. Jernigan-Noesi.
No, I think similarly, I was thinking about just going back to the language of kind of the multi-level. So also thinking about the narratives of folks and recently participating in a series of conversations with psychologists via the American Psychological Association, interviewing psychologists of color and other psychologists who work with communities of color in particular. And the predominant theme that emerged from those listening sessions were the fact that for people of color, right, what folks are presenting with, how they're presenting the symptomatology doesn't match a lot of what's in the DSM-4, including trauma. And so as I think about like the different roles that I hold and how important they are, it's again, the sort of both and of recognizing the system and the impact, for example, of the DSM-4 with regard to access to care and being able to get reimbursable mental health services. So there's a piece of me that would say, if we're sort of looking at tangible ways to really move the mark, recognizing that a few people, right, a group of people, have historically defined, trauma in its sense, and it has evolved when there's been attention to, right, the predominant narrative. So just the encouragement of really uplifting and highlighting the voices of those that are being served in an effort to continue to push forward in terms of recognizing that, in fact, right, there's a very limited, sort of focus with regard to our current definitions. And so how do we then force the field to really expand its definitions, which has huge implications, as I said, for other aspects at a policy level, as well as, when thinking about practice and how we're training folks, as well as, access to services. So that piece for me is there's different ways in which I think we need to influence current systems while always continuing to think outside of the box.
Thank you. Yes, absolutely. And Dr. Mendenhall.
Oh, I'll just piggyback and say that, people think and express and experience trauma in really different ways. So, we live in a really complex, culturally diverse country. So caring for people and really meeting them where they are really matters, and thinking about what words people use and, having space where people can share their experiences. And recognizing, the cultural idioms of distress are like an added page at the end of the DSM. So actually legitimately considering what those terms mean and what people are doing with them and what they're communicating on their own terms, because we know concepts of PTSD and depression, and anxiety are, westernized cultural concepts of suffering, right? So they're collections of symptoms, but not everyone experiences or expresses or cares for or recovers in the same way. And really taking seriously that families are different, ideas about suffering are different. People are actually, one of the most powerful books or kind of narratives I've kind of learned about is this book. I actually have it because I'm teaching. It's called Spacious Minds by Sarah Lewis. But it's this kind of idea about trauma among Tibetan Buddhist monks and nuns in Dharamshala in northern India, and how, why do these people who've experienced so much trauma, so much violence, why are their rates of PTSD so low? And it's because how they see the world is different than a Western, egocentric, individualized perspective. And in the United States, we also have people with all different perspectives, right? And sometimes these white normative perceptions of what is sickness or what is suffering causes a lot of harm. So reconceptualizing or putting more training in programs in psychology, in psychiatry, in general medicine, and internal medicine is really crucial.
Yeah, thank you. That's actually a great segue to my next question, which is that in the class I teach every year for our master's students, I have them do an assignment, a final project, where they have to think about the ways that epi methods in particular have fallen short in studying social determinants of health. And one of the consequences of that lecture every year is that students say to me, how can I, as a master's student, get involved or do something? And so that was my last question, was sort of a bigger picture question. What are the big action items that need to happen? My next question is for any of our students or BUSPH students that are on the call, what are some ways that students might be able to get involved and start to make a difference on some of these issues from where they sit?
Wait, are you asking the students? I'm sorry.
I'm asking you all. I'm asking you all if you know of resources you would suggest for students, ways to become active and involved that you would suggest for students for bigger initiatives.
Well, one thing I think is that in epidemiology and the study of epidemiology, social epi is often seen in the curriculum as like an advanced epi. It's a type of epi in the same way that cancer epi is or CVD epi. And it seems like we should do better as epidemiologists to consider social epi as part of general epi. Like you understand matching and case control studies, then you should understand the general methods. I mean, of course, there's going to be some, advanced social epi methods, but the way we're carving it out, I think facilitates that splintering between general epi and social epi methods. So I think it's pretty important to for us as faculty to embed those. But I guess as students without that, taking at least the social epi class would be useful. And if that doesn't exist at your school, then a general sociology course might be helpful.
Yeah, that's a great suggestion. Any other thoughts before we move on to the audience questions?
Sure.
Yeah, Emily.
Well, my students always say, well, what can we do? And I say, okay, well, you're really interested because I teach a social theory of global health class. And, I say, well, go into policy, run for office, change things. And we don't have enough scientists in political leadership. We don't, or socially minded scientists or, people who study this stuff. It is a path that, people really need to understand the complexities of politics and society that affect why people are healthy and how. And, all of the things that my colleagues here have spoken about today are things that need to be transformed and are impeded by lobbyists, right? Again and again and again. Profit is put in front of people. So that's one of the things that I always tell my students is run for office, make the change, make the vote.
Thank you. Dr. Jernigan-Noesi, anything to add?
Yeah, I would say, and I sort of think about how innovation, right, is offered to any given field or discipline or even thought process. And so I always encourage students to be vocal about their observations, right, especially in relative to institutions like, academia, right, as a place or a source of training. I feel like student voices, right, their observations, their ideas really push or facilitate, right, new thought, new ways of thinking. So I would say from the student perspective, sometimes it can feel intimidating, right, to sort of have new ideas to offer them, to present them, to maybe even think about, writing them, but that's critically important. And certainly if we think about it, think about this from the perspective of psychology, the new ideas and the paradigm shifts that have occurred, right, sort of generationally in terms of new emerging scholars. So there's definitely a place at the table, if not, bring your seat and sort of force your way into the table if need be, into the room and into the table to offer some new perspectives. They certainly, I find amongst my colleagues, are welcomed.
Thank you. Okay, with that, I'm going to move along to the questions from the audience. We have some great ones here. And I think also this first one might be best for you, Dr. Jernigan-Noesi, as our resident clinician on the panel. What recommendations do you have for screening for and addressing racial trauma as a social determinant of health in a way that is not re-traumatizing and more trauma-informed?
I actually do a lot of training mental health professionals. That actually was one reason why I sort of transitioned from my academic role to work with providers, because our training programs aren't really teaching mental health providers how to screen, understand, really integrate this into their clinical work or group work. So what I often say to folks is you have to understand race, right? How it functions, how it has functions, how it functions today, how it may, sort of function in the future. That is where I always start, because it is a matter of understanding how race shows up in the lives of individuals that then allows you to engage in conversation, right? To really hear the narrative of folks, to come from a place of humility and curiosity, so that you have an understanding of the types of race-related events in an individual's lives that really lie along a continuum, right? Some positive and some that are going to be negative, which then allows us to really assess the significance, particularly of the sort of negative race-related events that can lead to racial stressors that can rise to the level of racial trauma. What I find is most often the case, and with regard to even seasoned clinicians, is that they've never explicitly been taught, right? Other than sort of saying race is important. And so we present case conceptualizations by saying, okay, Maryam, that's me, right? Self-identifies as Black, racially and ethnically as African-American. And beyond that, there's no integration. So I always sort of take a step back and we start with just a real kind of literal, social, global understanding of race, right, as a social construct and what that has meant and what that means in terms of how race and race-related factors show up in the lives of individuals. That then leads to, right, being able to ask more questions, to understand from a developmental, contextual, and lifespan perspective, right, how race is showing up in both positive, right, which are our protective factors, as well as the potential for negative race-related encounters that can lead to racial trauma. And I think in addition to that, the extension for me is recognizing that it's not just interpersonal, as I said in my presentation, that we also need to, as we're asking questions about the systems that folks live, thrive in, that we have an understanding, right, of the systems that folks are integrated in and are attempting to exist in, so that we can better assess the impact.
Thank you. Thank you so much. The next question might be best geared to Dr. Mendenhall, since it's a little medical in nature. The Hippocratic Oath includes the words "do no harm," but doctors are not immune to racism, misogyny, and transphobia. There are many communities that have been harmed by systems and direct patient care in hospitals. How do we combat, limit, or treat exposure to medical trauma in individuals and populations? I wonder if in your work on diabetes, you've ever encountered that issue and done work on that.
I'm not a physician, first, let me say that. But I've sat in on hundreds of clinical visits, specifically with Mexican immigrants, mostly women, just because I worked for 5 years at Cook County Hospital General Medicine Clinic, and half the time they couldn't find the translator. And, in anthropology, which is really jargony, we call it the structural violence of clinical medicine. So, how systemic and institutional inequalities play out in that clinical encounter. And so it's really tricky because, it's easy to blame physicians, but it's the structure of American medicine in itself. So there's so many ways we could go through this. But I think really one important example is, attendings and residents at Cook County would see, so many people a day that they'd have less than 5 minutes to care for them. And this is an old story, but there's some really small things that can make a difference, even within this really abusive system in which we provide care or try to make space for care. For example, I would sit there with, translate for the patient, and then the doctor would be sitting at the computer, not even looking at the patient, entering everything they can so they can support the patient by getting them medication. And so many times physicians would say, oh my gosh, I just have to see if they have depression symptoms so I can get them depressive meds so then they can take their diabetes meds. So, the conceptualization of let's stymie the symptoms of depression so they can take care of the physical ailment, and that kind of complexity, completely masking. There's a woman, Maryam, who I talk about a lot in this care, but before I just give an example of why her story matters, the thing that people would say again and again and again after this clinical encounter is they never touched me. And the fact that people don't feel touched or cared for or seen, even feeling seen or heard, can be transformative for the patients, and so those small things really matter. The other thing I talk about Maria a lot because she was undocumented and she was in this abusive relationship with her husband and really dependent on him and experienced violence from a family member when she was really small and carried all this stuff with her. And we spent, a long time speaking. And then I interviewed her again 3 years later. And she had no depression symptoms, she had depression and was really in a bad place with her diabetes and everything. But then when I interviewed her 3 years later, and after her interview, actually, we had gotten her, I spent like 2 hours figuring out her access to a Spanish speaking psychologist. 3 years later, she had gone to the counselor for 2 years. She had no depressive symptoms. Her diabetes was completely controlled. She looked really healthy. She'd lost weight. She'd left her husband. She was living on her own with a friend and she got a job. So, it's not just looking at her diabetes outcome is better. It's all of this stuff. And she said, I really faced my trauma and I worked through all of this stuff. And I was able to do these things. Leaving her husband was probably the most transformative, and getting a job, and all of that is reflective in her physical and mental health. So that it's not an easy answer, but that kind of stuff matters.
Thank you so much. This next question I'll address towards Dr. Pamplin and Dr. Johnson, although the asker has addressed it to everyone, but maybe you both can go first. Can everyone speak to the limitations of existing definitions of trauma? Current definitions assume an individual must undergo an experience directly to be traumatized. Although, as Dr. Pamplin encourages us to think about, there's vicarious trauma experienced by communities at large. Recent example being the murders of Black and Latinx persons that many of us felt despite not being related to the individual. How can we expand definitions of trauma to include these at-large effects?
Yeah, I mean, I think that that definition is limited for two reasons. One is has to do with contemporary times, and one I think just has to do with framework. I think contemporary times has changed this idea of what it means to be exposed to trauma, because technology, the internet is fundamentally changed kind of like how we are able to how we experience things, right? We know far more than we would have known about our world and our, like, especially things that are outside of our kind of immediate face, that, you know, 30, 40 years ago. But I think especially, I can speak for myself personally, especially the videos that were showing. I know we had a weird kind of moment in time where it was like, we have to post the videos because people need to know that these things exist, that they're happening. And then like, I had to have a moment with myself of like, well, I believe they exist without seeing this video. So I don't need to watch this. I don't need to continue to expose myself to this. But that's, the early days of thinking about trauma didn't kind of have this vision of being able to pull it up on a computer and be exposed to that type of violence like that. So that's the first piece. The second piece, though, is I think that definition comes from, I think to Dr. Mendenhall's earlier point, this very individualistic kind of, rugged individualist perspective. So it's what happens to you that matters, and this kind of absence of the idea that, like, if you are in true shared community with others, that you feel the impact of what happens to your community, and I think that especially when that's community that has this kind of shared identity. So, I'll speak as someone so I've lived in New York City for 12 years now, and I can tell you that my mother is beside herself anytime she hears something about, an incident between cops and young Black men, and my phone gets absolutely blown up. But like, we can't try to pretend like that's not a valid response, because there's an understanding that there's a pattern that has persisted, and it's just much more in our face. And I think so, even outside of the contemporary idea of technology has changed things, I just think we've had a very individualized focus, not understanding that that's not how every community moves through this world.
Thank you. And Dr. Johnson, what are you going to add?
Yeah, well, so I'll add something, and it's a little different, but it's a little bit at the intersection of trauma and adaptive capacity, meaning like to what extent does a community navigate challenges? And I think communities and peoples with a lot of challenges just sort of deal with challenges. So when another challenge comes down the pike and they're asked about how hard that is for them, then they might say maybe not that hard. So I'll give two examples. The idea, my father has been a runner his whole life. I did not find out until about 2 months ago that when he was 16, he was just jogging in Philadelphia, got stopped by the police, was at the station for like 4 hours, and then my grandfather told him he wasn't allowed to run anymore. And I mean, I think for many people who are not Black, that would be a traumatic experience. And my father has talked about traumatic things in his life, but that was not one of them. That was more like, hey, this is life. When I did work on COVID, people were losing their jobs, people were getting sick. But all of the different surveys that did rapid assessments of mental health had white people reporting more higher levels of distress than Black and Hispanic Latino folks. And I think the idea was, because objectively, we know that Hispanic, Latino, and Black folks were losing more people and you know, objectively had suffering happening. I think there was some sort of adaptive capacity, or this is life, that interfered with an assessment. So what I would say is that we should be careful in using these trauma numbers to identify populations at need. Because if you do that, then you will say, oh, these college students, they're very traumatized. They need X, Y, and Z, when really they've lived a life that has communicated to them that they should not experience adverse things. And when they do, that's extremely distressing. I hope that came through. I don't think I have quite the scientific language for it yet.
No, that's a great point. It came through for me. Anyway, I hope it did for others as well. Actually, a question for you also that I feel like is a segue. Do you see differences in trauma experienced at the individual level, like sex abuse or rape, versus at the community and society level, racism, refugees, war? Is there a difference in the impact for either, a difference in response? There seems in the US to be a lot of focus on trauma and war and and is there a need to shift from such a centric focus to other areas? I'm wondering if in your ACEs work at all, I know that you saw that there were racial differences there in the ACEs experienced.
I think maybe there are differences. And I think they might be more similar than we think they are different. You know, a lot of partner violence is about the status of women in society. Police violence is clearly about white supremacy. So I think, you know, violence to children is about like the role that we say adults should play and that children should play. So I don't think it makes sense to rank one of them. Maybe it's worth contextualizing types of trauma within political systems. But I don't know that I'd say we should stop focusing on individual or collective trauma.
Absolutely.
But I agree with what Dr. Mask Jackson said, which is context matters. So the context in which you're experiencing violence matters.
Thank you so much. Well, Dean Galea, I see, is back, which means it's time to begin our wrap up. I just want to say thank you all so much for your incredible presentations, your incredible work. So sincerely, thank you for sharing your expertise and your time with us today. I'm sorry that we didn't get to all the questions. There were so many great ones, but with that, I'll turn it over to Dean Galea.
Well, first of all, let me echo thank you. First, thank you to Dr. Gradus for excellent moderation, introduction, and fielding the questions. Thank you to all the panelists and presenters, and thank you to the participants. I thought there were some really outstanding questions, as well as really interesting comments in the chat. You know, if I may editorialize for a second, I thought the issues that were raised by you all and that emerged in the conversation were really important issues for how we think about mental health going forward. I mean, this question about what we mean by trauma, what actually is trauma, what is and I use the word intentionally, quote, qualifying trauma. I think it's a really important question that came up several times. I thought the point that Dr. Johnson was just making right now at the end around the experience of reporting distress and given the burden of exposure that one has had throughout the life course and understanding all that within a life course framework, within a social ecological framework. I mean, these are questions that the field of mental health really hasn't even begun to deal with. I think at the clinical level, individuals, clinicians deal with it. And I'm often really quite struck by how much these things are sort of intuitive for individual clinicians at some level, but the field from a broader population-based science perspective hasn't begun to deal with it in any systematic way. And I thought the comments that you all made were really terrific grounding for anybody who would like to build on the scholarship and the practice that emerges from this. So I want to say thank you for what you taught me and what you taught all of us today. And thank you for everything you do in your work on a daily basis. Everybody, thank you for being part of this conversation. And thank you to our audience. Everybody have a good afternoon and a good evening. Take good care, everybody.